We are just about ready to start the next presentation. This is going to be a presentation by Dr. Caroline Roche, who also comes to us from the Memorial Sloan Kettering Cancer Center. And she is going to talk to us this morning about genetics and the opportunity for risk reduction.
Myself. Can you see my slides and hear me?
We sure can.
Okay, great. Good morning. Good morning, especially to the Let Every Woman Know team, Drs. Hardesty and Hope. I really appreciate the opportunity to be speaking here this morning. We have Alaskan weather here in New York, so it almost feels like I'm there, but certainly without the great company. So this morning, I'm going to speak on inherited GYN cancers and opportunities for prevention. This is a topic near and dear to my heart. Make sure I can expand. I have no disclosures, other than it's always hard to follow Dr. Dennis Chi, who's one of my surgical mentors at MSK. So in talking about inherited gynecologic cancers, I think it's very important to start by saying that we truly know more about this every day. 10 years ago, when a talk like this was being given, the focus was only on BRCA mutations, maybe Lynch syndrome. But now, in the era of modern genetic testing, we can identify multiple inherited mutations that will predispose a patient to developing a gynecologic cancer. Ovarian fallopian tube cancer, endometrial cancer, even some rare mutations associated with cervical and cancer of the uterine walls, the myometrium. So today I'm really going to be focusing on the most common genetic cancer syndromes and how we can prevent them. But I do think this is just such an exciting area, and hopefully this talk will be even different 5 to 10 years from now. Ovarian cancer is a very common inherited cancer. We know that in the United States, there are over 20,000 new cases estimated every year. Family history of ovarian cancer is the most important risk factor for patients. A way to kind of demonstrate this is that the risk of an average patient, a patient in the general population, is about 1 to 2%. But in a woman who carries a mutation, predisposing them to ovarian cancer, like the BRCA mutation, might have a risk of developing ovarian cancer up to 50% over their lifetime. So this is hugely important. There is no screening test. It's important to note that the most common type of ovarian cancer is a very specific type called high-grade serous carcinoma. And this is a cancer that goes onto the surfaces of the organs in the abdomen and pelvis, a little bit like what Dr. Chi was referring to in his talk. So why is ovarian cancer still such a deadly disease? Why is it so hard to treat? Well, one, it's very rare to have symptoms of early stage ovarian cancer. So patients don't know they have it until the disease has spread. The disease unfortunately spreads rapidly and early on in the disease course throughout the abdominal compartment. And there is no reliable test to find it early enough. So preventing the disease from ever starting in the first place is key to saving lives. How can we identify women who might benefit from prevention? Well, family history is extremely important. Certain things that might key a provider that a woman is at high risk is any ovarian cancers in the family, any breast cancers that occurred early on in someone's life or before menopause, any males in the family that have had breast cancer, multiple relatives over multiple generations with breast and ovarian cancers, and an Ashkenazi Jewish descent. And the table on the right here has some of the more common mutations associated with ovarian cancer that we see in families. We know that about 15 to 20% of patients with ovarian cancer will have an inherited mutation that predisposed them to getting that disease. If we could identify every individual with a predisposing mutation, we could actually prevent over 4,000 of the predicted 20,000 cases this next year. We know from studying these patients that are at high risk for ovarian cancer We're starting to understand more on how this disease starts, and it's leading us to knowledge on how we can prevent it even better. Even though ovarian cancer is called ovarian cancer, this might not be the proper name, because what we know from studying patients who are high risk for ovarian cancer with genetic mutations is that probably the disease actually starts in this fimbriated end of the fallopian tube, the finger-like end of the fallopian tube that sits right next to the ovary. We know this because in looking in the tubes of high-risk patients, we found the pre-cancer lesion to high-grade serous carcinoma, which is the most common type of ovarian cancer. We found this in about 5 to 15% of patients undergoing preventative surgery and up to 80% of patients who have ovarian cancer. No other ovarian precancer lesion has ever been identified. And so this has really allowed us to understand that the end of the tube is involved in the development of the cancer. And it makes sense, since the tube is open to the abdominal compartment, the disease can scatter easily and spread early before there's any tumor to identify or find early. One theory about how these cancers may spread throughout the abdomen and pelvis is that when a precancerous lesion starts in the end of the fallopian tube, it may exfoliate off or spread throughout the abdominal compartment before it even turns to cancer. This theory is called Precursor Escape. And this really speaks to some of the unanswered questions about the fallopian tube hypothesis, that we don't understand when the abnormalities develop and when they spread, even though we're pretty sure the fallopian tube is the site of origin. So what is our goal? Our goal is to intervene in high-risk patients before malignant transformation of these cells, before any precancerous lesions escape from the fallopian tube. So how do we identify patients at high risk? Well, first and foremost, we need to start with our patients who have ovarian cancer. So all women with ovarian cancer should be referred for genetic testing. If a mutation is identified in that particular woman, then all of her close blood relatives should be screened and tested if they choose to do so. Unfortunately, if the patient with ovarian cancer has passed away, we start with the closest blood relative. This is called cascade testing. And if we did this, we would identify many more patients with a predisposing mutation. Some of the most common genetic mutations associated with ovarian cancer are the BRCA1 and BRCA2 mutations. The BRCA1 mutation is associated with the highest lifetime risk of developing ovarian cancer. Up to 50% of women with a BRCA1 mutation will develop ovarian cancer over their lifetime. These patients will develop earlier onset ovarian cancer, with their risk starting to go up in their 40s and 50s. BRCA2 is associated with about a 20% risk of developing ovarian cancer over a lifetime. And in these families, we do often see male breast cancers. I mentioned that we're learning more every day. And in one area where we're really learning more is in other genes called moderate penetrance genes. These are genes associated with cancers, many of them associated with ovarian cancers, but the risk is lower than BRCA. So these mutations that I've listed here, and the most relevant of them are the BRIP1, the RAD51C, and the RAD51D mutations, are associated with up to about a 14% risk of developing ovarian cancer over a lifetime. So these mutations are lesser known, lesser risk, but still much higher than the baseline risk of ovarian cancer in the population, which is 1 to 2%. Lynch syndrome is a syndrome associated with several different genetic mutations that will predispose patients to a number of different cancers. One of them is cancer of the endometrium, which is the lining of the uterus. And those mutations can have a very high risk of uterine cancer, up to about 70%, depending on the mutation, as well as a risk of ovarian cancer, up to about 15%. Now, I mentioned high-grade serous carcinoma as one of the most common types of ovarian cancer. It's important to know that the ovarian cancers associated with Lynch syndrome usually represent different, more rare types of ovarian cancer, like endometrioid or clear cell. We think that these cancers may be more associated with ovarian endometriosis, and patients with Lynch syndrome may be identified as having these cancers along with uterine cancers. In terms of Lynch syndrome, we used to counsel patients based on kind of a general, if you have Lynch syndrome, these are your risks. But now, based on newer data, we're able to give patients much more specific information on their risks of endometrial and ovarian cancer, depending on their particular Lynch syndrome mutation. And as you can see here, some of the mutations like MSH2 are associated with a very high risk of endometrial cancer, up to 57%, whereas mutations like PMS2 are associated with a lower risk and a much lower risk of developing ovarian cancer. So we can individualize our preventative options for these patients based on their particular mutation. A note about screening before I talk about prevention. So screening is when you identify a cancer very early on in a very curable stage, as opposed to prevention when you prevent it from happening altogether. It's important to note that we have no effective screening test for ovarian cancer. And actually the FDA released a statement in 2016 recommending against screening tests for ovarian cancer, especially for women at high risk. And really their rationale was that using screening tests for patients who are at high risk may provide false reassurance for these patients who would otherwise take action to prevent their, to prevent ovarian cancer or reduce their risk. And so since these screening strategies have proved ineffective, it is really recommended that they not be used. Of course, women should still work with their doctors in their own individualized care plans. So moving on to how we can reduce risk in high-risk patients. We always say an ounce of prevention is worth a pound of cure, and that is absolutely the case with these cancers. We know that removal of the ovaries and the fallopian tubes, or risk-reducing Salpingo-Oophorectomy, is the gold standard best way to prevent ovarian and fallopian tube cancer. This can be performed via minimally invasive surgery, tiny incisions on the skin with a quicker recovery. And it's important to note that the pathologist is crucial during these operations because they perform a very detailed analysis of the fallopian tube looking for precancerous lesions. So in addition to a surgeon experience, it's important to have this done at a center with an experienced pathologist. We know that in BRCA mutation carriers, removal of the tubes and ovaries dramatically decreases the risk of ovarian cancer, taking their up to 50% risk down to almost that of somebody in the general population with no risk. We know that this saves lives and absolutely can be completely life-changing for families of BRCA mutation carriers. So people always ask, what about the uterus? What about hysterectomy? Well, Lynch syndrome is a syndrome where hysterectomy is very important. As I mentioned earlier, Lynch syndrome is associated in some cases with up to a 70% risk of developing uterine cancer. Well, removal of the uterus in patients with Lynch syndrome is extremely effective in preventing the onset of these cancers. This was a study published in the New England Journal of Medicine, looking at patients with Lynch syndrome who underwent hysterectomy versus no surgery. And as you can see, in the group that underwent hysterectomy, there were no cases of endometrial cancer and no cases of ovarian cancer. Seems like this is obvious, but it's very important to have studies that back up these surgeries that we're recommending for patients. So I mentioned earlier, there are a lot of different mutations. These mutations are very specific with very specific risks. The NCCN guidelines do detail these mutations and what the specific risk of developing ovarian cancer is, and at what age risk-reducing surgery should be considered, if at all. And so it's important to know that we time risk-reducing surgery based on the actual risk of cancer, as well as when that risk of cancer starts to go up in an individual. This graphic is very helpful. Over here on the y-axis, we have the risk of developing ovarian cancer, and here on the x-axis, we have the level of evidence to support increased risk, as well as the use of surgery, removal of the tubes and ovaries, to decrease that risk. And these different colored lines represent different mutations. And as you can see, the higher the risk of ovarian cancer with BRCA1 over here on the right of the screen, the stronger the evidence to support removal of the tubes and ovaries. Some of the moderate penetrance genes that might be slightly increased risk over an average person without a mutation might not justify as much the intervention of surgical risk reduction or removal of the tubes and ovaries. So what about removal of the uterus at the time of BSO or removal of the tubes and ovaries? When is that indicated? This is a very common question that patients ask when they come into my clinic. Well, certainly if the patient has Lynch syndrome and a high risk of uterine cancer, removal of the uterus and cervix is recommended along with the tubes and ovaries. The data for the risk of uterine cancer with a BRCA mutation is more limited. We only have several small studies that have asked this question. However, these studies are starting to point towards an increased risk of uterine cancer with BRCA1, with probably up to a 2 to 5% lifetime risk of endometrial cancer. And we do know that these endometrial cancers can be some of the more aggressive types. And actually, a recent study published this year suggests that even with BRCA2, there is probably a risk of uterine cancer in these patients. So the role of hysterectomy should be discussed, but it is not part of the guidelines. It's important also to discuss the role of hysterectomy with regard to hormone replacement therapy, and I'm going to speak on that a little bit further in a minute. With all patients, this should be individualized and surgical risks discussed in detail. I mentioned that the BRCA mutations are now being shown to have an increased risk of uterine cancer. It's small, but we as surgeons need to understand, well, what kind of risks are worth it to patients to undergo a surgery like this? How high does the risk need to be? And FORCE is a wonderful organization, Facing Our Risk of Cancer Empowered, who performed a survey of 550 women with an increased risk of ovarian cancer, asking their views on hysterectomy. And interestingly, in this study, only 6% of women said that a risk of 2 to 6% was sufficient to consider hysterectomy. So we do need to discuss this with patients and individualize this aspect of treatment. I mentioned that removal of the uterus might offer the opportunity for safer hormone replacement, and I think this is very important. I'll discuss in a minute how removal of the tubes and ovaries does result in immediate surgical menopause, and so many patients will be considering hormone replacement to treat those symptoms. We know that if the uterus is removed, that a safer hormone replacement therapy is an option, taking estrogen alone, versus if the uterus is in place, women need to take combination therapy with estrogen and progesterone. This was a very large study done in healthy patients. So these were not mutation carriers, but healthy patients who either had a hysterectomy or didn't, and opted either for hormone replacement, either received hormone replacement or received a placebo in this study. And it's important to note that the highest risk of breast cancer in this group was in the estrogen and progesterone group. These two dashed lines here are actually the group that received placebo. So basically the group that got nothing. And the lowest risk of breast cancer, sorry, I didn't mention this is a risk of breast cancer. The lowest risk of breast cancer was in the group that received estrogen alone. So in our patients with BRCA mutations who are contemplating hormone replacement therapy and also worried about their breast health, having hysterectomy may offer them the opportunity to take hormone replacements without the added worry of increasing their risk of breast cancer. So removal of the tubes and ovaries, I just mentioned, causes immediate surgical menopause and infertility. This is a significant concern for patients. We recommend that patients with BRCA1 mutations start considering removal of the tubes and ovaries at age 35. Patients with BRCA2 mutations that should start considering at age 40. So fertility might be a significant concern. This can be mitigated with assisted reproductive technology. Patients may choose, if they have the resources or access to this care, to freeze eggs or embryos. And then, of course, removal of the tubes and ovaries results in surgical menopause. Menopause is the lack of estrogen, which can result in significant quality of life changes, such as vaginal dryness, reduced sexual function, hot flashes, insomnia. There are also health implications like cardiovascular disease, bone health, lipid level changes. And this can be mitigated with hormone replacement therapy in many cases, but not all patients are candidates for hormone replacement therapy. And so this needs to be discussed closely with their doctors to determine what's right for them. Some patients find that premature menopause or the choice of having to take hormone replacement therapy is not acceptable. We do see that some patients will delay or even decline surgery to remove their tubes and ovaries due to concerns about menopause. And in a large trial of patients with BRCA mutations, about 36% actually opted to delay their risk-reducing surgery. So this to me says that patients deserve better options and that we need to be working towards providing our patients with better options. Removal of the tubes and ovaries can be life-saving for patients with mutations, but it does have significant side effects. We need to get better with menopause management. So we know there are a lot of non-hormonal options for menopausal symptoms. The genitourinary syndrome of menopause can be treated with vaginal moisturizers or dilators. And then vasomotor symptoms like hot flashes can be treated with acupuncture, lifestyle modification, or non-hormonal medications. Many patients who've had a history of breast cancer will be told that they can't take hormone therapy, and so these options are very important for them. We need a better focus on sexual health research for patients who are undergoing both cancer treatment and preventative surgeries, with an increased focus on women's sexual function. And we need better hormone replacement therapy options. So we know that estrogen replacement therapy is highly effective at reducing the side effects and health effects of surgical menopause. But some areas such as sexual health, it may not bring women back to baseline. And so this is very important for us to be investigating further. There was a study performed in women with BRCA1 mutations looking at the use of hormone therapy and demonstrating its safety in this group of patients. And most notably, the use of estrogen alone in patients who had had a hysterectomy was found to be the safest approach in this cohort. So I mentioned earlier that we think that the fallopian tube is probably the site of origin for most high-grade serous carcinomas, which is, again, the most common form of ovarian cancer. So the natural question to ask is removal of only the fallopian tubes an option? Removal of only the fallopian tubes would allow patients to keep their ovaries, keep their hormone function, keep access to their eggs. We know that this might be a promising approach. So we know that the fallopian tube plays a role. We actually have great data from studying populations of women that even tying the tubes will decrease a woman's chance of getting ovarian cancer. And we know from a couple very large population studies, like one done in Sweden of over 5 million patients, that removal of the fallopian tubes will actually decrease a woman's risk of ovarian cancer. What we don't know is the timing of this procedure and whether patients have kind of escape of those precancerous lesions before the fallopian tubes are removed. And we really don't know how much protection removing the fallopian tubes will provide to a woman with a genetic mutation like BRCA. So this concept is currently being studied in the form of early salpingectomy and delayed oophorectomy. So a patient might come in, say, I'm not ready for my ovaries removed. Let's just remove my tubes and plan to come back at a later date to remove the ovaries. We think that this might be applicable for patients who have completed childbearing or maybe who are planning IVF. Again, their ovary function is preserved. It's an overall low risk procedure. Doing this surgery allows the surgeon to look around the abdominal cavity and look for any precancerous cells. It allows the pathologist to look closely in the fallopian tube for precancerous lesions. We can still go back and remove the ovaries at the recommended age. So this is currently being studied in clinical trials and proposed as an option for women who are not willing to have their ovaries removed. There are pros and cons. It might provide risk reduction without the added risks of menopause. Again, it's an opportunity to inspect both under the microscope and with the surgeon's eye. And if we find one of those precancerous lesions, we can intervene faster. We don't know how much protection is offered. We don't know if this has any impact on breast cancer because some studies have shown that removal of the ovaries will decrease someone's risk of breast cancer. Patients would need 2 operations, one for the fallopian tubes and one for the ovaries later. And then, of course, there's the possibility that this may provide false reassurance and patients may not complete the ovary part of the surgery. There's currently 4 prospective trials studying this. 2 of them are being done in the United States. One of them is still enrolling, called the SOROC trial in BRCA1 mutation carriers. And all of these studies are studying this new concept of removal of the fallopian tubes only as a stepping stone to later removal of the ovaries. The WISP study, which has completed accrual, has released some preliminary results with final results expected very soon. And what we found in doing the WISP study was that while we didn't have enough time or patient numbers to show whether this was as protective as removal of the tubes and ovaries, we did find that in patients who had their fallopian tubes, that their quality of life was improved over patients who had the ovaries and tubes removed. And they also had a relief from their cancer-related worry over those patients who didn't have surgery at all. And of course, removal of the ovaries had worse menopausal symptoms than removal of the fallopian tubes, which does not have any hormonal impact. We are trying hard to understand better our patients' experiences facing these decisions. What is it like to be a woman with a genetic mutation who's faced with all these different choices? Tubes, ovaries and uterus, tubes only, ovaries later. So the Any Mountain Project that Dr. Hope mentioned earlier is actually funding some of this important research that we're doing to understand better the experience of patients facing these complex and difficult decisions. And we're currently in the process using support from the Any Mountain team to build a tool, a digital tool that's going to help ensure that every woman with a genetic mutation receives accurate information about her options for preventative surgery. So I just wanted to mention that and thank Any Mountain for their support of this work. Finally, this whole talk has been about high-risk patients, patients with mutations. What about women in the general population who don't have family histories, who don't have known risk factors? Well, we're trying to work on finding ways to prevent ovarian cancer in those patients too. And there is something called opportunistic salpingectomy, or taking the opportunity to remove the fallopian tubes when it presents itself. This is a procedure that is for average risk patients without a mutation, without a family history. And what this is removal of the fallopian tubes during an already indicated surgery, such as sterilization. If a woman wants her tubes tied for birth control, the tubes should be removed instead. If a patient's having a hysterectomy for a non-cancerous reason, the tubes should be removed even if the ovaries are staying behind. And possibly this could be done during non-gynecologic surgery, like if a woman was having a hernia repair or a colon surgery or a gallbladder surgery. And we are studying this, and this strategy has been predicted, if we can bring this to ORs everywhere, to significantly reduce the number of ovarian cancers diagnosed in the general population. And there is a lot of exciting work in this area coming in the next few years, so stay tuned for this. So in conclusion, I think I'm staying on time. Genetic testing and risk-reducing surgery can be life-saving. Pre-vivorship planning, or helping a patient who is a pre-vivor, someone who has a genetic mutation but hasn't gotten cancer yet, helping her plan her strategy with regard to fertility, menopause, surgical interventions is essential. And there is a lot more work to do. So we need to expand access to genetic testing to identify all high-risk individuals. We need to optimize our risk-reducing surgical options, not just stop at tubes and ovaries, but see how we can make that better. We need to improve the quality of life for previvors with better menopausal treatments and treatments of sexual health. And we need to find opportunities to prevent in the general population. And of course, we need to develop an early detection test. So I just wanted to say thank you to MSK Team Ovary, my home, my team. Of course, thank you to the Let Every Woman Know in Alaska group, my friends in Alaska. Of course, thank you to all our patients and their loved ones. And Dr. Hardesty will recognize this view taken from a room in her house when I stayed with her last time. So thank you for having me here, and I'm happy to answer any questions.
All right, thank you so much, Kara. As Dr. Boyd gets up and booting, I'm going to again take this opportunity to ask my question. Can you comment on what you think the role is of intrauterine progestin in women who hysterectomy is not performed as a potential safer way of doing hormone replacement therapy? What the data is on that, et cetera?
Yeah, I think that the most important thing is that hormone replacement therapy is going to be given, that we give it in the safest way possible. So I did mention that estrogen alone with the uterus out has been shown to be one of the safest approaches with regard to breast cancer. We do think that if a woman has her uterus and progesterone has to be given to protect the uterine lining, that an IUD, like a Mirena IUD, is probably a safer option than swallowing progesterone or receiving progesterone through a patch. I think I'm not sure if the data is robust enough to make kind of definitive statements on the safety of that with regard to breast cancer. But I do know that it's, in many patients, it's a better option than using oral progesterone or patch progesterone.
And I just want to remind, thank you so much for that answer, by the way. I want to remind everybody to put your questions in the chat box. Again, if you go down to the bottom of your screen, there's a little bubble. It says Q&A underneath. If you click on that, you can type in there, and that is the easiest way for us to see your questions.
I'm going to chime in there, Melissa. And again, thank everyone for giving me the opportunity to be a part of this. Dr. Long-Roche, awesome talk. Really appreciate it. It's always a pleasure to spend time with you talking about these sorts of things. Bunch of questions. So in your practice, what % of your patients with BRCA1, let's start with that, with BRCA1 mutations, are you doing a hysterectomy?
It's a good question. I actually find that with BRCA1, we're probably doing hysterectomy more than half the time. I think it's really individualized. Patients with a history of breast cancer who know they're not going to be taking hormone replacement therapy are less likely to choose a hysterectomy, because I think that the hormone management is a major kind of driving force. I also think it really depends on the patient. Different patients are comfortable with different levels of risk. And 2 to 5% risk of uterine cancer for some patients is not enough. I tend to take care in New York City, a lot of young women with BRCA mutations. And I do find that they tend to be more aggressive than some of the older patients who might want to minimize the surgical risk.
All right, great. Thanks for that answer. We have a question. The person's asking, or someone's asking, that clear cell ovarian cancer 11 years ago and had genetic testing at that time. Should she be tested again with newer tests? Can you talk a little bit about the difference in testing we've had for the past decade or so?
Yeah, that's an awesome question. So, the BRCA gene was identified, well within our lifetime. I was in high school when it was identified. So a long time ago, but not that long ago. The testing for the BRCA gene has gotten much, much better. So the test that we had in 2000 was not the same as the test we had in 2005. Looking at BRCA mutations in around 2013 or so, we started to expand genetic testing beyond the BRCA mutations to look for all these different moderate penetrance genes. And so I think that genetic testing does not equal genetic testing. And so if a patient thinks that maybe they've had it a long time ago, they should bring their test results to their doctor to see what specific mutations were evaluated and tested for. And if a full panel was not done, these tests should absolutely be repeated, because they can be very important for an individual's health and the health of their family.
Great. And I think this goes back to the slide that you showed earlier, the pie chart, looking at all the various mutations and how we've expanded our knowledge dramatically with that. Another great question in the chat, you mentioned menopause-related vaginal changes, and there was an interest in Mona Lisa therapy, which was a vaginal laser therapy. Have you heard about this, and what do you think about it?
I have heard of it. I have had patients use it. I, as a GYN oncologist and cancer surgeon, have never used it myself. I don't have experience with it in patients. I know that there's some mixed data on whether it is effective. So I would say that it is something that you should talk to your general gynecologist about. The Mona Lisa laser is used to treat atrophy. I should have mentioned that. Atrophy is thinning of the vaginal tissues. Atrophy can be associated with pain and discomfort, urinary symptoms. There are other therapies other than the Mona Lisa, which is a laser, that can be very helpful, like moisturizers that are very safe. Some moisturizers are natural, like vitamin E suppositories or coconut oil. And then for some patients, estrogen suppositories can be very helpful as well. So I'm not a Mona Lisa laser expert, but hope that answered it a little bit.
I think that's definitely helpful. And I will add to that. Yes, I also, as you know, Karen, not a Mona Lisa expert, but there was a tremendous buzz about this the first couple of years that it came out. And I have to say, I had some patients who I sent to get it done, who then reported back to me a lot of marked improvement, but I don't know if that was noted long-term. So initially, I think they had great results and then kind of petered off. So that might be the issue. But certainly there are separate venues to look into that further. All right, there's another question about a patient who had breast cancer in remission for 10 years, went through menopause and related to breast cancer treatment, is 51 years old, BRCA negative. Should she remove her tubes and ovaries?
This is a good question. And obviously we can't provide specific medical advice without knowing a patient, knowing all about her history. But there are some patients with breast cancer who are recommended to remove their tubes and ovaries just as a way to decrease their estrogen levels in the sort of goal of treating their breast cancer. That's separate than kind of what we're talking about, which is removing the tubes and ovaries to prevent ovarian or fallopian tube cancer. In terms of the choice as to whether to remove them to prevent a cancer, it really depends on whether genetic testing shows anything and whether there's any family history of ovarian cancer. And if there's not, and another, then it really would be an elective procedure and not something that we would kind of recommend to everyone. But of course, if another surgery is being done at the same time, that would be one of those opportunities to remove the fallopian tubes.
All right, great. Another question. So what's your surveillance strategy now for patients at high risk? I think it's clear that there's no clear benefit to a surveillance strategy in average risk patients.
Yeah.
But there are some agencies suggesting we shouldn't even be using a surveillance strategy for high risk patients. So what do you do in your practice?
So I have a long conversation with all of my patients. So if a patient is high risk and comes in, we sit down and we talk about everything. And I explain that I explain the data on screening, because I think it's very important for patients to know that the screening tests that have been studied, like ultrasound and blood tests, sometimes they find an ovarian cancer, and everyone knows someone who had an ultrasound and it found a cancer. But what is really important is doing those tests in someone with no symptoms has never reliably been shown to save lives. And in some cases, we worry that it could be harmful because it may provide false reassurance, because it really isn't an effective test. And we wouldn't want someone to put off their preventative surgery because they felt reassurance from an ultrasound. So I really make sure people understand that. I do have patients who still really want to have ultrasounds, and I'm fine with that. And so it's a shared decision, but it is not something that I routinely recommend for patients. And the most important thing is just close communication with their GYN and their GYN surgeon to understand their pre-vivorship plan when they're going to take action to move forward with preventative options.
Great answer. What's your thinking about salpingectomy off trial? Are you offering it routinely now, and how do you go about that?
It's a good question, because ideally every person who has their tubes out would be on a clinical trial so we can learn from them and use that information to help other patients. Unfortunately, the trials are not comprehensive. So right now, the only trial that is enrolling patients for a fallopian tube study in the US is SORAC, and it is only for women with a BRCA1 mutation, and it's only for women who aren't planning pregnancy in the future. And so a lot of women who could benefit from this aren't eligible. And so we do offer it off trial to patients who kind of fit the criteria. We are hoping in the next few years, not to give away some things that are coming in the pipeline, but to have a national registry for any patient who has their fallopian tubes out in one of these capacities to kind of register their information. So even if you're not on a trial, you can be a part of the data collection. But we do offer it to patients who are well counseled and feel like it's the right choice for them.
And how do you, if a patient, because I have patients coming to me all the time and saying, well, what do you think, doc? Should I take out my tubes and ovaries or just my tubes? How do you deal with that question?
I'm kind of a stickler for the guidelines. So if someone, we say first, let's just use BRCA1. We say remove the tubes and ovaries between 35 to 40. If someone has reached age 40, I say, I think your tubes and ovaries should come out. The most important thing to me is keeping you here and alive. And so I'm kind of a stickler to the guidelines. But if someone has not reached 40, especially if hormone replacement therapy is not an option for them because of a history of breast cancer, I do think the tube option is a great stepping stone to allow them a little more time with hormones before they have to go through surgical menopause.
Let's step back for a second. Would you mind? I think we're talking about these kind of surgical options very theoretically, but can you talk a little bit about like what the specifics are? What is it like to have your tubes and ovaries out from a surgical perspective, not from the long-term kind of hormonal issues, but the day of surgery? What are you doing? How long does it take? Kind of what's involved?
So these procedures can almost always be done with minimally invasive surgery or laparoscopy. Tiny incisions in the skin. The biggest incision is about the width of a dime. 3 incisions usually when I do tubes and ovaries or just tubes. If patients are also having their uterus out, 4 tiny incisions. In my OR, some other ORs, 3 to 5 incisions. Patients come in, they go to sleep with general anesthesia, they have their surgery, they wake up with some Band-Aids on the skin. For all of these procedures, patients can usually go home the same day. First 2 to 3 days are usually the hardest with some bloating from the gas that we use in laparoscopy. But after that, the recovery is much faster than traditional open surgery. And usually patients are kind of feeling back to normal 2 to 3 weeks later. Great.
Yeah, I just wanted to emphasize that the actual surgeries are pretty straightforward and patients do great with them. Another set of questions, you showed in one of your slides that the prevention from these surgeries is amazing. I mean, the benefit that we get from this relatively small surgery surpasses so many of the other interventions we do for really almost any cancer that we treat. But it's not 100%. And can you discuss kind of why isn't this 100% effective for patients who are at high risk?
Yeah, so it goes back to that picture I showed with the fallopian tube right next to the ovary and the little cells exfoliating off. And when I explain it to my patients, I say, we think these cancers start in the end of the fallopian tube, and it might be like a confetti cannon spitting little cells all over the abdomen. So when we remove the tubes and ovaries, people can still get high-grade serous carcinoma in the lining of their abdomen. It's a very low risk, probably 1 to 2%. But we theorize that comes from these little cells that maybe weren't even a problem when they shed off and either were precancerous or became precancerous, after kind of shedding into the lining. It's one question that I ask that I don't know the answer to is a lot of the data about the risk of these cancers after ovaries and tubes were removed comes from years ago when patients were having these preventative surgeries at an older age. I'm very curious to see now that we're finding BRCA and other mutations younger and we're doing these surgeries at a younger age, whether that risk of peritoneal cancer will go down. Because there's less time for that fallopian tube to be in there. I don't know, but that's the theory on how they can happen.
All right, ladies. Well, as much information as we have learned, I do unfortunately have to close this session up, and it's time to move on to our next session. So thank you very much for that great information. And with